hesitancy right here on the continent. How this is going to play out here on the continent and how ready the continent is to averting a third wave, more like even pushing back the Indian variant, is our focus today. Welcome to VSA. I'm Sulaiman. You know, the most amazing thing about India is that the country has been, giving out COVID-19 vaccines to the rest of the world. They shared vaccines like candies as the world turned to the second most populous nation for help. Now, these are tough times for India, as a sharp turnaround in fortune has seen the nation clutch its vaccines tightly. The effects are evident on the rest of the world, especially Africa. Now, the B11617 strain of COVID-19 is the latest enemy, albeit faster, harder to combat, and more dangerous. Now, the strain discovered in India is killing thousands as Africans stay alert to the concerns of a previously unknown enemy. Now, nations are locking borders, flights are getting grounded, and restrictions are once again the way out as Africans rise to the impending doom of a potential third wave of COVID-19. Yet to bounce back from the effects of the first wave, hardly recovered from the second wave, the third wave may ask questions many African nations can't answer. So African nations are struggling to get enough vaccines for their population, and where they have enough for the moment, citizens are hesitant. Multifaceted, hydra-headed, the fight against COVID-19 is on. Well, joining me to look at these, Dr. Peter Imoesi, a research fellow, University of Aberdeen in Scotland in the UK, and of course, Dr. Victor Ngani is a group medical director, RFH Healthcare in Kenya. Gentlemen, good to have you both here on the square.
Thank you, Suleiman.
Well, good to see both of you again. But again, let me start with Dr. Ngani. Looking at what's playing out in India, what's your major concern? Seeing footages, pictures, and of course, information coming from India, what worries you the most?
Well, the biggest worry is where we were when COVID-19 started. And our concern back then was that if COVID-19 were to come into Africa, then the images that we were seeing in India, that is what we had envisioned for Africa. Remember, our health systems haven't been the most robust. We have struggled across pretty much every country, with the exception of a few, to create adequate healthcare resources, put up the infrastructure, employ the healthcare workers, and therefore the possibility that COVID-19 would overwhelm our feeble healthcare resources was a very real concern for us when COVID started about a year ago. Now, then we went through a phase where the whole world was more or less, Africa confounded all the scientists, and we had this sort of pattern that had not been replicated anywhere else, where we'd have very brief, limited waves, and then followed by a big space where we don't have many infections. But then what's happening in India now, which is a year on from COVID-19, shows us that there's still a possibility that we could experience something similar to what we have seen. That's the first thing. Then there's a second discussion about these new strains. As you correctly said, the B1617 variant, which has been famously called the double mutant, the new strain. And every strain that comes up, the indications that it spreads more easily. And there's a possibility that some of these strains will end up being more fatal. And therefore, the concern that we are facing now as healthcare workers is that there are new strains every day. And we don't know to what extent the sort of immunity that has been acquired by infections in society, even by vaccinations, to what extent these measures will protect us against the new strains. So these are the two concerns. Number one is a warning sign that there's a possibility that the structures we have will be overwhelmed. And by the way, the understanding has been that India has a better healthcare system. I don't know how true it is compared to Africa, but then the possibility we'll struggle is real. And the second one is these new strains.
Well, Peter, does that also resonate with you? Because I also recall you had warned the continent, especially Nigeria, to keep watch. But looking at India, what truly is a concern for Africa?
Thank you for having me once again on your program. Just to pick up from where Victor left things is people have kind of argued that the Indian country, they do have better health care compared to Africa. And I think in the last time I was here, I was saying that that is relative. It depends on what you want to define as better health care. And when it comes to the situation we have in India at the moment, I know we do have two variants and a new strain altogether. So the first variant is called, I think, the B1516 and B1518. Then a new strain that's called AP. So the difference between all these variant and strain is that for the variant, it means that you have a few mutation within this particular coronavirus we have already. And those mutations, for instance, for the new variant we have in India, they are kind of somewhere around the RBD, which is a receptor binding domain of this particular virus within the spike protein. And like you know already, the spike protein is where the virus uses to gain access into the human host. So this current variant have kind of altered that particular shape, thereby leading to what you call immune evasion or evading the immune system. That is one hand. On the AP level, which is the AP variant, what that means is that the whole virus is changed completely. So when you hear the word variant, it means that you have a new organism altogether. So it means that you have the normal variant ongoing in India, then you have a new organism completely new altogether when it comes to the COVID-19 fight. Now, am I worried at the current cases we have in India? Well, I would say that India, they kind of behaved recklessly. I'm sorry to say that, because there was this model they had sometime in December where they did a mathematical simulation, and they went about saying that they have a significant level of herd immunity of about 60-something%. And based on that, they went all out to approve vaccines, Covaxin, Covishield as well. And the reason for that approval at the time, they were saying that in case of emergency, they will have therapeutic to deploy immediately. Again, I think the Indian government were more interested in business side of things. And well, people will say they kind of help the world. But the way I look at things is that there was this article that says that with the sales of their COVID-19 vaccine, is going to revamp the economy. So rather than focusing on their 1.4 billion people, they went about giving out about 70 million COVID-19 vaccines around the world, about 68 countries or thereabout. And here they are right now, a country that is known to be the largest world producer of vaccine cannot actually cater for their own people. So first and foremost, their policies were wrong from the beginning of December to this moment. 2, the political rallies were ongoing. 3, you have their religious activities ongoing, people converging in rivers and what have you. And 4, there was a wrong scientific information saying that these individuals do have a significant level of immunity. So basically, it's not the virus that is so virulent, it's the behavioral pattern of the people. So I will use UK as an example. We had the B117, which is still ongoing anyway in the UK, that is also virulent as well. But what we did here was to impute the cautionary measures, which is a total lockdown. At the same time, increase our vaccination program. And like you are aware also, recently, Boris Johnson came out and said it's not just a function of the vaccine that brought down the cases in the UK. It is more of the restrictions we had in place, whereby we kind of tackle, on the other hand, using the vaccination of the elderly quite rapidly. So basically, if India go ahead to start vaccination right now, if they have the vaccine, which I'm not aware of, is that it's going to take about 3 weeks for people to start having that reasonable level of immunity going forward in their population. So I think right now they are really at a very edge where it's kind of a blink for them as a country and as Asia countries as well, because they're within the Asian continent and people around them, Bangladesh, they are locking down their own borders as well. So I think it's really difficult for India at the moment.
Well, Victor, listening to both of you, what really worries anyone watching at the moment is some of the key things raised by Peter, and it has to do with, keeping to the COVID-19 protocol, because he's just said that more people, especially in the UK, were able to get off, being infected because of the lockdown, not as a result mainly of the vaccine. Now, looking at what's happening in India, just recently we spoke to a student leader in India who also spoke about the cultural and religious festivals in India as some causes of the spike. Tell us, perhaps Africans should start looking at, is Africa or Africans, are they dropping their guards? Are they letting their guards down? Keeping in mind, in focus, what Peter has said about the attitude of those in the UK and how the lockdown is responsible for the, drastic reduction of infections in the UK.
Indeed, we can actually agree significantly. I think Dr. Peter and I, we are of the same opinion that to some degree, India was premature in its declaration of victory. And if you witness what they did, they then said, okay, we've overcome this, we've managed COVID-19 effectively. And this is because they saw a decline in the rates of COVID-19 in their communities. They felt the measures were adequate. They did some antibody studies, which suggested that they had gotten significant immunity in the society. But the real, and I think many countries, not just India, I think it would be unfair to single India out and say that India is doing something uniquely different. And that's where the danger lies, because if you look at many African countries, they're not different. In fact, the only difference perhaps is that many of us don't even produce vaccines. Our health systems aren't, there's a relative nature of it because inequalities are as real in India as they in Africa, where there are those who have greater access to healthcare as compared to others who are not as privileged. Again, those dynamics are similar. But then in this continent, in Africa, we have more or less sort of done more or less the same thing, where there is a wave and multiple reports in the media. And then as the numbers begin to go down, then precautions are sort of thrown out of the window. So India went back to political rallies, they went back to religious events, and they more or less opened up the economy. And the consequence of that is that what we don't know about COVID-19 actually came back to haunt us. And I'm speaking about this globally. Now, when I say coming back to haunt us, I mean Indians, Africans as one people. And the precaution there, and I think it's not just the fact that India relaxed its measures, but the very fact that in Africa we're doing the exact same thing. That's what should worry us. In Kenya, the pattern has not been very different. We had at some point towards the end of last year, we had a wave around November, and then very quickly the government took some measures. The measures were a bit more stringent, and we sort of went into a half lockdown kind of a measure. Schools were closed, pubs and restaurants were closed, even places of worship were closed. Political gatherings were reduced, and the wave was brought under control. Towards January, February, everyone felt we were done with the wave, and we reopened. All the bars, people were celebrating without masks, people going into discos, political rallies everywhere, schools were reopened, and by mid-March, we were literally running out of beds. And what has been shown is that these measures, however small they are, they actually work. Because thereafter, after March, then the government put in place measures, and in just about a month, we are beginning to see a decline, significant decline, and a reversal of that pattern. So yes, it's true to say that these measures, whenever they're put in place, you'll see a decline, and the absence of these measures causes a reverse. However, it would also not be proper to fail to acknowledge the role of vaccines. Israel is a very good example of one country that has vaccinated more than 60% of its population. And as a result, the decline in numbers has been tremendous. And this is one of those cases that we are studying to give us confidence and perhaps give us hope. The UK itself, despite the success of its measures, also has witnessed significant success in terms of vaccination. And the true, the true tale will be told when after reopening and after vaccination, we fail to see a spike. you see what has been happening before is that every time there's a downward trajectory, then communities reopen, and then suddenly there's a new surge. And this is the first time that we'll be reopening in many countries after vaccination. And it will be quite interesting to see what that does to the COVID pandemic direction.
Let me bring in Peter here now. Peter, let's see if we can get into the laboratory now for a moment. What makes this Indian variant more dangerous?
Like I tried to explain initially, although people have different opinions when it comes to if this particular variant is deadly or not. Also, you can also compare that with the B117, which you have here in the UK. Then you can also compare it with the B13525, something like the South African variant, then the P1 variant in Brazil. Now, when you look at all these variants, there's something common among them. It's called the E484K mutation. And this particular mutation is what this particular variant uses to kind of go one step ahead of the vaccine or the natural immunity. But again, I still want to bring it back to the point where I believe that the behavioral pattern of the people is what is actually driving the spread of this particular virus. So first, if you're trying to go fast ahead of the virus, first you can do a lockdown like we did in the UK. Then you quickly vaccinate the vulnerable age group, which we did as well, which is 60 and above. So we did that really rapidly. Then we also went ahead to do vaccination of the frontliners, health workers as well, quickly. And also before we went down to the next age bracket and people with comorbidities. So our own vaccination was more like a lockdown kind of vaccination where people were not so exposed to the virus. So as you were vaccinating, people were developing immunity gradually. Don't forget that when you take the first jab of Oxford AstraZeneca, you have immunity of about 55%. That is the level you have in the first dose. Then the second dose is where you're able to raise up to 72 or 76% efficacy when it comes to the trial they did. So clearly you could see that if you vaccinate today, it's not a yardstick that you're going to have that immunity you're looking for. So because that is not a yardstick that you're going to have that immunity you're looking for, it means that vaccination side-by-side lockdown is the way to go first before you do a wide-scale opening or any level of opening. I may also remind you that we had the toughest lockdown in the world. We're at level 4 lockdown in the UK, and it was only about a week ago we started opening gradually. And last week, Friday, the UK government did a trial study where they allowed people to converge at a particular pub, a club in Liverpool. Then they did 24 hours test of COVID test. I think they were also vaccinated as well. Then after 5 days, they will present themselves again to do another COVID-19 test, the PCR test. What they are trying to do is when you have this kind of mass gathering, what will be the level of exposure of these individuals? That is one. Then two, will the people who are vaccinated already, will they have that level of immunity to weather the storm going forward? Now, when you bring this down to Africa, for instance, from the very word go, when it comes to this pandemic, to be very clear with you, let's use Nigeria as a case example. The only time we had a very tough lockdown was sometime in April, March last year. And after that, almost everyone returned back to their normal life. You could see that religious centers that have about 50,000 capacity, 100,000 capacity, every Sunday and Friday, they are full to capacity from the very beginning. So clearly, it shows that even when we had the B11 variant in Nigeria, which there are other variants as well we are yet to identify, it means that there is something going on in Africa that is kind of shielding against this particular pandemic. So it's not a function of we behaving recklessly, because from the beginning, we've behaved recklessly. We don't really have the social amenities to keep people at far distance. So clearly, there is something going on in Africa where we're not really presenting the cases. Now, when you look at India as well, I think the average median age of the Indian population is about 26.8% thereabout. Now, about 67% of the 1.4 billion people fall within a particular age bracket. Now, when it comes down to the older population, they have about, I think, 6.3% of their older population. Now, of that 6.3%, about 63 and above, that is 63 people age and above falls within a particular age bracket. So clearly there's a little disparity when it comes to the age demographic between Africa as a continent and also India as a country as well. And also when you look at the social amenities in India, their level of living is really poor. You know, they just left off from the most poorest country in the world before it came down to Nigeria, which is still under context anyway. Now, when you look at this level of amenities, they are densely populated environments, there are easy accessibility to healthcare facility. You could tell that once they have this kind of scenario they have now, it will really hit them real hard. Now, to buttress my point again is where they did the initial clinical trials for Covaxin and Covishield. There was this report on CNN where they were saying that people in rural areas were given about, I think, $3, which is about 750 rupees. And that particular inducement was for them to come out to get the clinical trial phase. And people kind of came out in droves, and so you could tell that clearly when it comes to the level of poverty, there is also high level of poverty within the Indian population. And based on that particular scenario, when you have any form of variant at all, with the level of convergence of people is going to spike. And once it spikes, if you have high number of people who are vulnerable, high number of people who have comorbidity, they will definitely succumb. So the virus will not move if you don't move, and the virus will not infect an individual if you don't adhere to the non-pharmaceutical interventions. But when you let these guards down, you will have the case you have right now also between India and Brazil. But in Africa, despite we're not really adhering to this non-pharmaceutical intervention, apart from South Africa, the number of cases we've reported in the last 11 or 12 months is just somewhere around 123,296. As of today, India, they've reported that's fatality now about 229,756. So a whole continent or a country could see the level of differences when it comes to the level of fatality. When it comes to recovery rate as well, in Africa, we have total cases of about 4.6 million. Now, of that 4.6 million total cases, we have about 4.1 million recovery. So you can see that Africa has a high level of recovery compared to any continent at all in the world.
The thing there is that you said it all. If you don't move, you won't get the virus, because the virus on its own can't move. I'll come back to you, Peter, because there's something about India and its youthful population, which the country did say was helping it fight against the virus. I want you to tell us more on what actually happened there. But coming to you now, Victor, the thing here is that quite a number of issues need to be looked into, on the continent. As it stands, the numbers aren't actually looking good for India. Apart from the cultural issues, religious issues, which we have seen as a result of all that is happening at the moment in India, are there other things scientifically that you think should be indicative of what India is dealing with? Keep in mind that some of them have already been vaccinated.
Indeed. And before I come back to that question, allow me to clarify a couple of points. The variant in India now, you've heard of the term double mutant, which is more a political term, really a lay term, because scientifically it pretty much makes no sense. The same variant you're looking at has another 11 mutations combined. And the reason it's called double mutant is because it has two infamous mutations, one from the variant seen in California and one in Brazil, both of which tend to make the virus a little bit more easier to spread, and also able to evade, it's suspected able to evade immunity that has been created either through vaccination or through having had the disease. Indeed, that begins to answer the question that you've asked me to some degree. The second point, just to pick on something Dr. Peter mentioned, you see, in places like the UK, it is possible to do a complete lockdown, and people will be fine because they have social protection measures. The government can come to the rescue of the population. But in Africa, it's not so easy, because then the decision becomes whether to have a meal or to avoid COVID-19 when you lock down completely. In fact, in Kenya, what you've done at best is you've had curfew running from 10 p.m. to 4 a.m. So that, or even earlier, 7 p.m. all the way to around 4 or 5 a.m. in the morning, depending on the season, and then closure of certain activities. But complete closure, as has been seen, complete lockdowns, as have been seen in the West, for Africa it's been demonstrated not to be realistic, because many families then end up going hungry, and even in these partial lockdowns, it has been complicated by these measures. However, even these partial lockdowns that are being implemented across African countries, these have an impact, and I do agree fully that these measures should be implemented.
I think
India,
you're painting a picture now that, well, Africa, the only thing left for Africa is to ensure that the virus, we don't witness a resurgence of the virus here on the continent, because if you're not affected by the lockdown, you just might be affected by the virus. So do what Peter has said, abide by the COVID-19 protocol, and stay away. Peter, I come back to you, and it has to do with the very youthful population that India once, boasted of having. Having Nigeria in mind, Nigeria also says we have a very youthful population. Perhaps that is what is helping slow down the virus in Nigeria. What are those things you think Nigeria should be doing now that we have seen that that actually didn't work for India?
When you try to compare the youthful age between India and Nigeria, like you earlier mentioned, in terms of context, India, like I said initially, they have 26.6% average median age of their population. In Nigeria, the average median age is 18.1. That is the first comparison. So it's not so far off. And when it comes to the percentage of people who are within this particular age demography, for the 26.1% of Indians, they fall within the 67%, 67% of the total population of 1.4 billion. Whereas in Nigeria, the 18.1 average median age, it falls somewhere around about 50 to 60%. So clearly you could say that we have a more similar age bracket when it comes to the youthful population. Now, like you said, what can we do in Nigeria for us not to come down with the cases we have in India or in Africa? From the Nigerian Bureau of Statistics of 2016, we're made to understand that people who are 60 and above in Nigeria are somewhere around 9.6 million people. That is far back 2016. So when you look at that particular number, let's just add a few figures to it as 2021 today. Maybe people who are 60 and above in Nigeria may likely fall around 12 million or 10 million at the very least. So clearly you can say that we don't really have that age population in Nigeria, that is to start with. Then secondly, when it comes to the rural areas, we have more of our elderlies living in the rural areas of Nigeria. Now, these particular rural areas, they are kind of dispersed. They live in a dispersed way, whereby when it comes to crowded, the number of densely populated villages or towns is really very few. That is one. Now, when you compare that to Indian as well, their own population is not, both the elderly and the young, they are all kind of densely compact in their own kind of climate, because it's a 1.4 billion people. So just imagine the whole of Africa, we are 1.3 billion. Now that 1.3 billion is the same population a country has in their own landmass. So you have 1.4 billion people. So the level of social distancing or social amenities will really be difficult for India. Now for Nigeria, how can we weather the storm going forward? I've always said on this platform that for me, like one of the WHO earlier mentioned on this same platform as well, he was of the opinion that we should kind of lay down the first, second, or third wave. Let's just go ahead and say we are still in the pandemic. Now, when you look at the testing we are doing in Nigeria, you are aware that we are not really testing as we should. At the same time, when it comes to the numbers we pick on daily basis, when it comes to total number of tests, it's not kind of correlative with what you have on the next or the previous day. So clearly, we're not really tracking the virus down. Maybe the virus is even 10 times ahead of us. For reasons we don't know, the cases we have in Nigeria or in Africa, they are not really that severe compared to other countries or other continents as well. So first, let the government go ahead to lock down their borders. That is one. Then two, you advise people to stop this mass gathering because maybe there's a variant that is out there that is kind of warming up to be able to invade our own kind of system. And by the time that occurs, we may likely fall in the same track where India are at the moment, because clearly we don't really have the vaccine to vaccinate our people. That is one. Then two, we have high level of vaccine hesitance on the country and in the country and on the continent as well. And Sudan is a case example. Recently, they had their vaccine destroyed because those particular doses were expired. And that's because people refused to come forth to take this dose as it were. So clearly, there is something we should look into and check exactly what is going on within our own people.
We'll take a moment. When we come back, we'll talk more on especially the shelf life of the vaccines, because some Africans are already alluding to the fact that perhaps, or to the insinuation that it looks like the vaccines were, manufactured even before COVID-19, and that is why they have gone expired. And also, we'll also be looking at South Africa that has just taken delivery of the Pfizer AstraZeneca. And the quick question is, are they going to have the J&J as well as the AstraZeneca from Pfizer simultaneously in that country? That will be when we return. Join us again. Welcome back. Here's our home stretch here on VSA. So far, less than 5% of the entire African population has been vaccinated, with South Africa, which is the worst hit nation on the continent, having less than 0.5% of its population getting vaccinated. Delay in acquisition of vaccines and hesitancy have become costly and dangerous to the battle against the virus. While some nations have rejected vaccines available after new results from research conducted elsewhere, the Africa CDC has said it's not a good decision. In the words of Dr. John Nkekazong, the Director General of the Africa CDC, he said, "You don't go to war with what you need. You go to war with what you have." So the question is, what does Africa have? Well, we still have Peter Imoesi and, of course, Victor Ngani here with us. Gentlemen, thank you for your time. Quickly here, Victor, let's quickly look at Africa and how much it has done in the battle against COVID-19. We've seen quite a number of things. How important is it for Africa to know why the disease is less devastating on the continent. So if we consider India's previous position and where they are currently, then we may be on a cliffhanger.
Indeed, Suleiman, you're spot on there. You've actually hit the nail on the head with that one, because look, India was, COVID-19 is new, but it's not that new. It's a disease that came more than a year ago in, you know, we are way past a year, probably a year and a half since it came into existence. And early last year, late last year, India felt pretty safe. It was sitting pretty, which is pretty much where we are. And there are many factors that contribute to this. Number one, how connected a country is to other parts of the world where, you know, the travelers coming in. That's a significant portion. India right now attracts many medical tourists and other tourists for different reasons. Again, Dr. Peter has mentioned how, you know, it's a smaller country, a smaller geographical mass with the same, actually a bigger population than Africa. And so these factors should act as warnings to Africa, because more than a year after the pandemic, India is in the middle of a crisis. A more connected country, a country that's more densely populated, a country that was also sitting pretty as we are. And therefore, at this juncture, we probably shouldn't be on that space of feeling safe. We should actually be getting ready and learning from the lessons that have been, you know, seen in India. And it's super important at this juncture for us to pick those lessons. We don't know what variants are coming up next. We don't know the impact of that. The concept of young population, that is true to some degree, but only to some degree. If you consider the percentage population that you know, is affected in Kenya, for example, now 7% of our population gets severe or critical illness. That's a big population. Slightly less than 2% of this population is going to pass away from COVID-19. You can extrapolate this to the whole of Africa. And that is a significant risk. And I think we shouldn't be sitting pretty at this time. Yes, it's important for us to pay attention.
Yeah, Peter, looking at, the good thing is you schooled in Nigeria and have this scenario, you know, up there in your head, someone telling you that he or she does not believe that these vaccines have just been manufactured. Else, how come some have just gone expired so quickly? So it brings again conspiracy theories. Only experts like yourself can actually better explain to that Thomas or someone who still thinks that this vaccine has been there even before COVID-19.
First, the vaccine were not there before COVID-19. That is the first explanation to that. The reason is this. So when, let's use Oxford AstraZeneca as an example. So initially, when Oxford AstraZeneca announced their initial candidate vaccine, because at the time it was called a candidate vaccine, because we're not so sure if that vaccine will go through the phase 1, phase 2, and phase 3 trials successfully. Because I think GSK, they had their own vaccine that actually failed eventually. I think either GSK or Merck, one of them. Now, what happened is that when the candidate vaccine went through the first phase 1, most of these companies went ahead to mass produce already and kind of stock them. So it was a risky game. And people should kind of thank this. They should be very grateful to these scientists and these companies as well. So imagine you trying to stock up a warehouse, then you're not so sure if the product you have is going to be accepted by the populace. That is one. You're not so sure if the product you have is safe for people to consume. But yet you stock up your warehouse with the mindset that once the research goes through, you're going to have the result you're looking for. So that is what happened. So if, for instance, we have vaccine expiry now, it's not because they were produced before the pandemic. It is because as at the time they did their clinical trials, they went ahead to massively produce this vaccine and store them ahead of time. So if the clinical trial goes through successfully, it will be easy for us to roll out the vaccine so quick. So usually what you should have done is you do a small production of the vaccine, you go ahead to do your trials. Now it takes a whole lot of time to produce 1 billion vaccine to start with, or half a billion vaccine also. So it there means that as at the time Oxford AstraZeneca got a green light in December, that is when we'll start rolling out the vaccine to meet the demand of the people. And by now, I'm sure UK won't be off the woods, or any other country, or Israel as well. So because of that proactive measures, and also the level of commitment by government, scientists, and resources available, science is all about funding. Once the money is there, scientists can do whatever they want to do as quick as possible. And also, people were willing to volunteer for the clinical trials. There is never a time in the history of the human race where you can amass about 32,000 people to volunteer for a clinical trial. It's never that easy. But when it comes to this COVID-19, we had that number for Oxford AstraZeneca. And when you merge the number between Moderna and Pfizer, they had about 70,000 volunteers as well. That is massive. So people bought in immediately, and it was easy to recruit these people. So we have a clinical trial here also where we're trying to recruit people. It is really difficult to recruit people into a clinical trials because you're telling this individual that you may likely get a placebo. So it means that you're not really getting the drug itself. So you're also at risk. Then the other individuals that will get the drug, they are not also sure if they are getting the drug or the placebo. But even at that, people were willing to come forward to volunteer themselves. So first, we should be grateful to the scientists. Second, be grateful to the government that were willing to fund and put in the resources as when due with the risk available. Then third, we should be grateful for people who were willing to volunteer themselves for the phase 1, phase 2, and phase 3 clinical trials. So if the vaccine are expiring now, it's not because they were produced before the pandemic, is because as at the time the vaccine had a green light in the first preclinical trial phase, they took in the risk and they went ahead to massively produce this vaccine with the mindset that the vaccine will go through. So for companies like, I think Merck, that they could not have their vaccine up to clinical trial phase 3, all what they've produced may likely be destroyed. And that is huge fund wasted, huge time wasted, and effort from individuals. That is the case study here.
Well, Victor, considering Africa's population demographics, will it be dangerous to limit vaccination and harp on non-pharmaceutical interventions?
Well, the fact of the matter is right now vaccines work. And while it is true that the efficacy of the AstraZeneca vaccine against symptomatic disease is about 67%, the effectiveness and the difference here between efficacy and effectiveness is something that I want to highlight. Efficacy is what we are testing in the lab conditions and everything, the ideal conditions, and effectiveness is what we see in the real population. The effectiveness against severe disease, critical illness, and death is close to 100%. And as it stands today, people who've gotten both doses, we are not aware of people who've then gone ahead to die of COVID-19 as a result. And so the big issue is not contracting COVID-19, it is dying from COVID-19 or getting severe COVID-19, or now we are looking at what are called the long-term effects of COVID-19 that linger on for more than 12 weeks after the illness. And we were just looking at this the other day with a different team. So in Africa, we ought to embrace vaccination, especially for the vulnerable populations. But even as I say that, there's a lot of caution that we want to highlight because, yes, you've spoken about these infections, these ICU cases overwhelming the system, but a big discussion that's coming up now are these long-term effects of COVID-19. And what we're seeing is it doesn't matter your age. You could have had a symptomatic illness, and yet you have lingering symptoms for a very long time. You could be a very young person, even children, and you have lingering symptoms for time that we are not sure how long that's going to be. Then there's a part that we don't know about COVID-19. It's very hard to have predicted what's happening in India now. And I'm certain this is not the end of that story. There's a possibility new strains will arise where even the vaccines may not be adequate. So at this juncture, what we have, and I'm glad this was said by the CDC, Africa CDC, and what we have right now, let's use that. We are not at that space where we're able to choose and say, I'd rather have something that's super polished, as long as it's safe, let us go ahead and use it. And this vaccine is safe. I've had it personally, and I'd encourage anyone who has a chance to take the vaccine to take it. This is part of how we save ourselves. However, very important, this does not replace the precautionary measures. In fact, those measures take precedence over vaccination. Vaccinations are an added advantage, but our primary go-to place is to make sure we take precautions. Believe it or not, COVID-19 is preventable by non-medical options, and that is something we can leverage on as a society.
Peter, you've always talked about how much of testing we're doing on the continent, especially in Nigeria. So if you look at it, the record doesn't look good. Africa hasn't tested 1% of its population, and we have a new variant we are battling with. What's the possibility of having a deadlier variant, undiscovered, who knows, on the continent?
The possibility of having just today from Kenya, where 5 people were detected to have the Indian variant already in Kenya, and you've had the SA variant, you've had the UK variant, you've had pretty much every variant, and the capacity to test for variants is not present in all countries, and this is an area of concern. Look, we are not even testing for COVID being there or not. We're not testing enough. The US, for example, has tested more than 250 million people. That is, that number compared to what we've done in Africa is astounding. By the time India is recording 350,000 positive cases in a day, you can imagine how many tests they have done in that day to get to that rate. And so you look at Africa and you realize, number one, you're not testing.
Let's let Peter weigh in on this. Peter, go ahead.
When it comes to the testing, I know that there are a few factors involved when it comes to the reagents. So most of the reagents required for testing are not produced in Africa. And also, if you look at Nigeria as an example, most of the reagents we use are imported. So that is one angle to it. So when you had a lockdown initially in early 2020, there were issues with supply chain, and that's why, because with the supply chains in place, then Africa CDC had this roadmap where they had a massed number of consumables. Then they distribute these consumables among the member states on the continent. So that is one. Now, would there be a deadlier variant that we've not picked up yet? Well, the answer is there, because when it comes to variants emanate based on the behavioral pattern of the people. So if, for instance, an individual contracts COVID-19, for instance, and he or she stays within the confinement of their homes, that variant, however deadly it is, dies there once you recover. But once that individual starts moving around the places, then the possibility of spreading the virus is as very high as possible. So clearly, when it comes to identifying this variant, the only way you could do that is through genomic surveillance. And in Nigeria, we have about 4 genomic surveillance in the country, and a number of African countries do have 1 or 2 surveillance as well. But even at that, no matter how good your surveillance system is, the fact that the people are not adhering to this non-pharmaceutical intervention will always make the virus be 1 step or 2 steps ahead of you. So clearly, what we need to adhere to, I know it's really simple and easy to do without, is first, wash your hands as quick as possible. If you don't have running water, use the alcohol-based sanitizer. Use your face mask when you're in crowded areas. Then as much as possible, avoid social gatherings. And with that, we can mitigate the spread of possible variants that may be there or that may be deadlier when it comes to the behavioral pattern of this virus in the nearest future. Now, when it comes to the vaccine, let me just weigh on this quickly. When it comes to the vaccine, we know that coronaviruses, once you have that level of immunity from the natural infection, the immunity you have could last for 6 months. So let's look at that based on the vaccines we have. Now, there is no study yet to tell how long the immunity we get from this vaccination will last for. So based on that, it means that if, for instance, you are vaccinated today and the immunity you have will not last for more than 6 or 8 months, or at best 12 months, then it means that you're going to have this top-up dose every now and again. And that clearly says that the non-pharmaceutical interventions are more like here to stay for a little longer before we are out of the woods completely when it comes to COVID-19 pandemic.
I was actually going to ask that question, but you just nailed it, because we're seeing different variants: Brazilian variant, India variant, the UK variant, and the question many will be asking, is it that COVID-19 has come to stay? But quickly, let me come to Victor. We haven't actually scratched the surface on the South African issue of vaccination. Let's see if we can actually close with that. Victor, do you think, or is it advisable that the country, now that we know that the continent hasn't actually done enough in terms of vaccination. Does it make sense scientifically to go ahead with those two types of vaccines in South Africa, J&J and AstraZeneca?
Well, South Africa did a study pretty early on where they concluded that the AstraZeneca vaccine wasn't as effective against some of the variants that they had. I've not looked at the latest development on that, but at some point they discontinued the vaccination of the people using the AZ vaccine, and they were exploring both J&J and the Pfizer-BioNTech vaccines. And as it stands now, there is significant data that supports, initially you were saying if you take one particular jab, then you take the next jab. But there is no data suggesting that, in fact, getting two different vaccines is okay, and there's data supporting that. The research is ongoing. And then in terms of having two different sets of vaccines in the population, that also works. I think the UK has been trailblazing on that to some degree. They had both the Pfizer-BioNTech vaccine and AstraZeneca, though they were giving similar shots to the people. And by and large, all these vaccines have been shown to be safe, and then against severe disease and critical disease and death, all of them are actually almost equally effective in preventing almost 100% these kinds of situations. Therefore, in Asia as well, vaccination using whichever vaccines are available is likely to help in the fight against COVID-19.
And Peter, what do you think South Africa should be doing at the moment?
For me, I think South Africa are kind of very brilliant from the very beginning. I really give it to them. When it comes to understanding the pandemic, they were far, far ahead of many other African countries, even the Western countries as well, because they were the first to identify that the Oxford AstraZeneca may not be effective against the South African variant. Now, for them to have gone ahead to deploy two platforms, which is the Pfizer, BioNTech, and Johnson & Johnson, I think is the right way to go, because when you look at the level of fatality on the continent, South Africa actually reporting high number of fatality. That's why we have the 123,000 cases already when it comes to fatality. So going on two platforms is really commendable. And also, I think when it comes to acceptability, the government have done a good job. Their scientists have done a good job as well. And I think there's really reasonable level of confidence between the population and the people leading the pandemic. And for me, I'm also very comfortable with the way the science is coming forth from South Africa. So they are actually on the right trajectory. And in the next couple of days or weeks, they may likely have vaccinated a reasonable number of their population, and they may be on their way to easing the lockdown. Now, to wrap up things clearly, I would say that when people say 65 or 70% vaccination is required to get to the level of herd immunity, that number, I think, is arbitrarily, because it was just set by an individual. There is no any form of research to back that up, because when you look at coronaviruses, for instance, if you vaccinate an individual today and the level of immunity is waning out clearly, it shows that with the number of months going down the line, you may likely have to do a booster dose, which is what we are targeting right now. By September in the UK, we are hoping to induce the booster dose within the population of 60 and above to get them fully protected against the winter that is coming. So this vaccination is more like going to be there like just the flu jab we have on a yearly basis. So the first thing is, let's preach the good news of the vaccine. At the same time, let's boost the acceptability of this vaccine among the population. Once the population buy into this vaccine, I'm talking about Africa now, once this population buy into this vaccine, then we could say that, we have a reasonable level of people who are vaccinated. So if you have half vaccination, for instance, then we really have issues when it comes to herd immunity on the continent.
Well, it's a fine place for us to leave it. The key thing there is that everyone must ensure not to drop your guard, ensure that you keep up with the COVID-19 protocol, because for more than a year, Africa has actually fared well in the battle against the COVID-19 pandemic. And when many thought the war may be coming to an end, the enemy has improved its arsenal with another variant. Not too good a story. Once again, the continent must step up to the challenge and win. Thank you for being such nice company, Doctors Peter, Imoesi and Victor Ngani. Hopefully Africa will win this, and Many more battles to come, and all thanks to you and your colleagues. I'm Sulaiman. I'll see you again tomorrow. Bye-bye.